This is Dr. Daniels, and I am lecturing for Level 4, Test 3, Emergency and Disaster Nursing. So why do we even talk about this? We have over 115 million people visit the ED annually, and this number is increasing. And there's lots of reasons why. They can't see their primary care provider. We have this aging population that we talked about in Test 1. There's shorter hospital stays, so people are coming back more frequently for readmissions. There are many acute mental health care crises, and there's also just a lack of health insurance or primary care providers. So we're getting lots of overcrowding in our EDs and long wait times. So if that's the case, how do we best meet those who really need care the fastest? So one way we do that is by triage. And we use ESI, and this is how it's basically a triage method that we use to help see patients. There are 5 ESI levels. The first level is bad. These patients are unstable. They use a high resource intensity. They have big threat to life or organs. These patients require immediate life-saving intervention. Second level, these patients have a threat to vital function or to organ function, and they do use a lot of resources or a lot of high level of resources. So they're bad off, but they're a little bit more stable than the level 1s. Three, so we're looking at down here, 3, this is kind of the danger zone because these patients are stable, but they possibly could go to the bad side. So it's hard because when we triage someone as a 1 or as a 2, they're going to get a lot of attention, a lot of care. These 3s have a possibility of kind of falling between the cracks, so we have to be careful. They use medium to a high amount of resources. An example of this would be someone with abdominal pain. Could it be just something simple like constipation? Yes. Could it be something more serious like internal bleeding or even a ruptured appendix? It's hard to tell when they come in and their chief complaint is just abdominal pain. So they're going to use some resources. It's not like we can just do an exam on them and send them on their way. They're going to get an x-ray or a CAT scan of their belly to see what's going on. They may get some lab work. So they're using resources to kind of figure out what's going on. 4, right down here, these patients are stable. There is no threat to vital function, and they use a low amount of simple resources. So they're typically going to get a physical exam, maybe get like 1 or a very simple diagnostic test, but they're not using many resources. And then 5, these are the patients where we say, why are you here at the ER? Why didn't you go see your primary care? These patients are very stable. There is no threat to vital function, and they typically don't use any resources whatsoever. It's an exam only. An example of this would be someone with like a cold who came in and we listened to heart and lungs, make sure there's no wheezing, make sure there's no signs of like a bacterial infection, and just explain to them symptomatic treatment. So again, this ESI level is a process of rapidly determining the patient's acuity. Are they 1s where they're really unstable, they have a compromised airway, they have a brain bleed, something horribly bad, or something in between like abdominal pain level 3, or something very stable, simple, like a cold? Obviously, we see patients that are leveled as a 1 first. So even if a patient who is a 5 has been there for 4 hours in the ER waiting to be seen, they will continue to wait if a patient is labeled a 1 and comes in has only been there 5 minutes. Most critical is always treated first. Okay, so your primary survey. A, airway. Airway always includes C-spine stabilization. So most of the time we use this jaw thrust maneuver, and we always use least to most invasive. So airway may just be using a jaw thrust to keeping the mouth and airway open, and it could be most invasive like, intubating. B is breathing, the respiratory effort. So this is where we're going to look at the patient. Are they having any dyspnea? My recording got stopped. Not quite sure where I stopped, but I'm going to go back to B, breathing, respiratory effort. So this is where we look at the patient and see, are they having any dyspnea? Are they having chest wall movement? What are their breath sounds like? C is central pulses. So we're looking at the patient and determining the rate, the quality, their skin color, their temperature. D is disability, basically their level of consciousness or their GCS. We can also use things like AVPU, which is alert, voice, pain, unresponsive. We talked about GCS in test 1 when we talked about increased ICP, less than 8 intubate. But D is basically their disability, their LOC. E is their exposure or their environmental control. So this is where we want to be careful, because at this point in time, let's say a patient's been in a car accident and at the scene, they've stabilized the airway, the patient's breathing, they've got good pulses, so they've got fluids running and they're nice and pink. We know that they're like a GCS of 12, but we want to start looking for other things. So we start removing their clothes for a good physical exam, but we have to be careful that we don't cause any significant heat loss. If at any time a life-threatening condition is found, an intervention is started before moving on to the next step of the survey. So if, for example, right away at airway, we notice the patient's airway is compromised, we are going to go ahead and get an airway before we go on. If we get through A and B and C, and then all of a sudden at central pulses, we come across a weak, thready, pulse, or we notice that the patient is losing blood, we're going to go ahead and apply pressure to that area to stop the bleeding or to go ahead and start fluid so that we can get good pulses. So anytime we go along this, we always start with A, we move our way down A, B, C, D, E, but at any point throughout this continuum, if we find any life-threatening condition, we're going to start an intervention at that, where the condition is found, and before we move on to the next step of the survey. So secondary survey, this you can see at it's table 69.5 in your book. And this is brief, systematic. This is where you identify all the other injuries. At this time, you're going to get a full set of vital signs. This includes typically a blood pressure on both sides bilaterally. You're going to get your heart rate, your respiratory rate, oxygen, temperature. So full set of vitals. Then this is where monitoring and tubes come in. So this is where you get the patients hooked up for their EKG. You have their pulse ox going. You may put a Foley or an NG in at this time. You may be sending blood off to the lab. Family, we really support their presence. There's been a bunch of studies done. Families like to be present because they like to see that the medical staff is doing all they can. Comfort, pain control. Sorry. At this point, this is when we use both farm and non-farm techniques to control pain for the patient. We need a history, detail of the incident, the illness. Something like ample, or which includes allergies, medical history, past medical history, last meal event. We really need to know what happened to the patient. If they were in a car accident and they got hit in the chest, how did they get hit in the chest? Was it from the seatbelt? Did they hit the steering wheel? Did they get ejected from the car? All that's going to determine how we go forth and treat this patient and help us guide our care to know which diagnostic tests we need. We want to log roll these patients. We want to really maintain C-spine. Tetanus prophylaxis. Most people cannot remember the last time they had a tetanus shot. We do ongoing monitoring and always evaluate the patient's response. Obviously, if something we're doing is not helping, we need to reevaluate and try something else. And at this time, we're going to prepare to transport the patient. Either they're going to get transport up to the floor, or they're going to get transported to get more diagnostic tests done, like a chest x-ray, or they may be transported to another facility, or we're going to, like I said, admit them. All right. So there's a difference between emergency and mass casualties and how we prepare for it. So an emergency is an extraordinary event, something out of the ordinary. It does require rapid and a skilled response, but it can be managed by a community's existing resources. So think of like a car accident. So a car accident is an extraordinary event. Two cars collide on the highway. The ambulance from the local hospital is dispatched. They come to the scene. They are skilled. They treat the patients. They get them to the right hospital. Police may get involved to redirect traffic during that time, but it's normally cleaned up within a couple hours, and the community moves on. The difference between an emergency and a mass casualty or a disaster is one, they typically are man-made or natural events. So like we all just went through our Hurricane Irma. And it overwhelms the community's ability to respond with the existing resources. Again, we all just went through this. When, 75% of the county lost power. We were down with internet. Schools were closed. Shelters were open. We required resources outside of our community. How many of us saw power trucks from North Carolina, as far as Nova Scotia? So it overwhelms the ability of the community to respond with the resources they have right there. There is a large number of victims, typically well over 100. There's physical and emotional suffering. Sorry about that. There's permanent change within the community. I mean, those poor islands that are getting beat up right now, their buildings have been, torn down. There's a permanent change within that community. And it requires assistance from outside sources. So the American Red Cross, FEMA, JACO, there's DMATs. Many of you are a DMAT team, got called into the hospital to work for several days in a row. All right. So with emergency and mass casualty incident, again, we need a system to quickly triage patients and take care of them. So this is a system of colored tags, and they designate both the seriousness of an injury and the likelihood of a survival. So again, the seriousness of the injury and the likelihood of the survival. So green, this is typically done very rapidly, 15 seconds. So when we have a mass casualty incident, something like recently the bombing at the Boston Marathon, they're going to quickly come in and start tagging patients. It's done super quick. 2/3 of the patients are going to be green and yellow, which we're going to talk about in just a second. But the majority of your patients, almost 70%, are going to be green and yellow. Only 30% require being admitted. And of those 30%, only half of them will require surgery within 8 hours. Typically, hospitals can expect that the number of casualties they get, they take the number of casualties they get in the first hour and they double it. Most of the patients that come in within the first hour to the hospital. So green is just a minor injury, no critical injury. Yellow is non-life threatening. Again, it's not a critical injury. Red is a life-threatening injury. Blue, they're expected to die. And black means they're dead. So these teams that go out there that respond to these mass casualties will quickly assess the patient. They are going to treat the reds first. Unfortunately, if you are labeled a blue or black, then you're expected to die or already dead. They're not going to utilize as many resources. And I know that sounds harsh, but if you think about it, again, when we talk about mass casualties and we talk about this where it's over 100 people, they're trying, and we have a limited amount of resources, they're going to focus those resources to do the most good. So what are your nursing considerations? Why is this important to you? Well, as we just saw, many of us haven't gone through mass casualties before. So it's really important for us to be well aware of how our organization's emergency response plan is. A lot of times a mass casualty or the threat of a mass casualty is a good way to assess whether or not your institution is prepared or not. We need to receive regular annual in-services to remain competent. This is why BLS, ACLS are, renewed every couple of years, because most of the time we don't have to use them. But when we do need them, it's going to be really important. So we need to continue to receive annual in-services. And then we need to participate in disaster training drills. All right, sorry for the phone calls. It's busy as usual, but I hope that gave you a quick little brief overview of disaster and emergency planning. I'll see you guys in the next lecture.